You have dedicated years to becoming an occupational therapist. You have the skills, the passion, and the drive to help people live their lives to the fullest. But textbooks may not have fully prepared you for getting paid for your incredible work. This is not just about business, it is about sustainability. Understanding reimbursement is crucial whether you work in a hospital, a clinic, a school, or for yourself. Without steady payment, you cannot continue the high-quality care your patients deserve. It is the engine that keeps your practice running. It allows you to buy equipment and pay staff, and invest in your professional development. Think of reimbursement as the financial heartbeat of healthcare. Each evaluation and each treatment session has a value. Medicare, Medicaid, and private insurance translate that value into payment. These systems are intricate, filled with rules, codes, and documentation requirements. Small mistakes can cause denied claims and delayed payments, creating administrative headaches, especially for new OTs. Break it down, learn the fundamentals, and you will gain confidence. This guide demystifies reimbursement and explores major payer systems with clear steps. My goal is to empower you, not intimidate you. Mastering these concepts secures stability, advances the profession, and keeps OT accessible. Let us get started. We will break it into manageable pieces so you get paid for essential work. In the United States, there is not just one way to pay for healthcare. As an OT, you interact with a mix I call the Big Four. These are the primary sources of reimbursement. First, Medicare, federal health insurance primarily for people 65 and older, and some younger people with disabilities. It is massive, regulated, and sets standards other payers follow. Next, Medicaid, a joint federal-state program covering millions, including low-income adults, children, pregnant women, elderly adults, and people with disabilities. Because states administer it, rules and coverage vary significantly. Know your specific state guidelines to ensure you get paid. Third, private insurance, employer or individually purchased plans. Each payer has its own rules, networks, and fee schedules. To get paid, you typically need to be credentialed or in-network. Benefits vary. Deductibles, copays, and covered services differ by plan. Finally, school systems have a unique reimbursement pathway. OT in schools is often funded under IDEA to support a free appropriate public education. Payment may be from district budgets, with potential billing to Medicaid or private insurance. That overlap adds complexity you will learn to navigate in the sections ahead. Medicare is a cornerstone of American healthcare, and you will work with it. It primarily covers people 65 and older, and some younger with long-term disabilities, ALS or end-stage renal disease. Medicare is divided into parts. Part A covers inpatient hospital and SNF. Part B covers outpatient home health agency visits and hospital outpatient. Know which part you are billing under. Services must be medically necessary. Treatment must be reasonable and necessary for the diagnosis or condition. Your documentation is your proof. Avoid vague notes like, patient worked on dressing. Instead, patient required skilled OT instruction and tactile cues for adaptive strategies due to post-stroke hemiparesis, improving safety and independence. This level of detail is non-negotiable. A simplified step-by-step for Medicare. First, verify eligibility and coverage. Second, obtain a signed plan of care. Third, use correct CPT codes. Examples include therapeutic activities codes and self-care management codes when appropriate. Finally, submit electronically and follow up. Example, Mr. Smith, 72, post-hip replacement, Medicare Part B. Get the referral, perform evaluation, and create a targeted plan of care. Bill self-care/home management codes for adaptive equipment training. Document progress, connect activities to goals, and show OT skills were essential. Medicaid provides a critical safety net for low-income individuals and families. Unlike uniform Medicare, Medicaid is administered by each state within federal guidelines. Coverage, reimbursement rates, and billing procedures can vary widely by state. What works in Texas may not work the same way in New York. Study your state Medicaid website. Enroll as a Medicaid provider. This is separate from Medicare and private credentialing and can be lengthy. Do not provide services expecting payment before approval. Verify eligibility before every visit. Eligibility can change month to month, and services without active coverage are unpaid. Use the state portal for real-time status. Document medical necessity, link to functional deficits and treatment goals. Many states require prior authorization, especially for long-term treatment or expensive equipment. Submit your evaluation and plan of care for approval before proceeding. Skipping prior auth is a common denial reason. Scenario: At an Illinois pediatric clinic, a 5-year-old with autism is covered by Illinois Medicaid. Ensure your clinic is enrolled, verify eligibility, perform evaluation, determine weekly OT to address school-impacting sensory challenges, submit evaluation and prior auth for 20 sessions. After approval, document each session and bill per state procedures. Private insurance is the third major piece of the puzzle. Most people get coverage through employers. Benefits vary widely. Determine if you are in-network or out-of-network for a plan. Credentialing vets your license and background and can take months. Start early. Always verify patient benefits. Check deductible, copay, coinsurance, and visit limits. Never assume coverage. Use correct CPT and ICD-10 codes, and follow any payer-specific rules. Some plans require prior auth. Others review documentation after several visits. Denials happen due to errors or payer disagreements. Track, appeal, and resubmit denied claims promptly. Example: Miss Davis PPO plan. Copy card and verify benefits. Learn she has a $500 deductible not yet met and a $40 copay per visit afterward. Communicate clearly. Submit the claim. The insurer applies cost to her deductible, sends an EOB showing what was paid and what she owes. In schools, OT is viewed through an educational lens, not just a medical one. Funded under IDEA, OT is a related service supporting free appropriate public education. Teams decide eligibility together. Assess how handwriting, attention, or sensory processing impact school tasks. If OT is needed, it is written into the IEP with goals, frequency, and duration. Your salary is usually paid by the district using local, state, and federal funds. Districts may bill a child's Medicaid or private insurance to recoup costs. It is allowed under IDEA, but cannot harm the family. No reduced lifetime limits or copays. Document sessions linking to IEP goals and justifying medical necessity. Example: fine motor training supports medical skills and educational outcomes like using scissors. We covered Medicare, Medicaid, private insurance, and school systems. Be diligent, be detailed, be proactive. Verify eligibility and benefits, document medical or educational necessity, code correctly, and follow up and appeal when warranted. Policies and coding change. Stay informed. Mastering reimbursement lets you focus on patients and ensure your care is valued and paid for.